it's not just infection, right? There's all these different etiologies that can start this common chain of inflammation that can lead to death. What if that's actually a better model for this than what we've been talking about? What if instead of the World Health Organization, we look at it this way and we say burnout is sort of the endpoint of a chronic inflammation, a cascade that can be caused by a lot of things. First one I came up with was inadequate self-care. It's not there anymore in my model because I don't think inadequate self-care causes this. I do think it's a comorbidity. I think it makes it more likely to get it. It makes it more difficult to get over it. But it's probably not an etiology. We were talking earlier, I think a big one is failure to recover from injury. All those paper cuts and sometimes big injuries we have at work. We don't take the time and we're not given the time to recover from those. And then the big one is moral distress, which can be personal, societal, or institutional. Now, I struggled with what to call this, right? Because you come up with a new paradigm, you've got to give it a nice, catchy name that's got nice, catchy initials, right? And so initially it was physician distress syndrome, PDS, my favorite suture, okay? I loved it. But I had a good friend who was a nurse practitioner who came and said, it's not just physicians, but no worries, you can just call it provider distress syndrome. But I don't use the word provider. And we can talk about that later if you want to. So you have to come up with a plural for all of the people that take care of other people. And what I've come up with so far is healer distress syndrome, because that's actually what we're doing as a group. I'm up for suggestions if anyone has a better plural for everybody in the hospital that takes care of other human beings. The understanding of inflammation, sepsis, and septic shock has evolved, and the current models, however they describe them, still work, because at the center is distress leading to an endpoint of burnout. We still have the causes of failure to recover from injury and moral distress. I've now put inadequate self-care off to the side. But there's one that I didn't think of initially that I actually have come to believe is the most important cause of this distress in medicine, and that's isolation and marginalization. It continues to work. If you look at dysregulated host response, that's breaches in professionalism, relationship failure, substance abuse, depression, and anxiety, all the things that are signs of a healer in distress. And the life-threatening alcoholism, drug addiction, and suicidality, all of which are preventable causes of death in our colleagues. And this model, because we're physicians, and particularly for surgeons, we understand exactly what to do with this cascade, right? It's source control. Remove, decrease, or modify anything that leads to failure to recover from injury, moral distress, and most importantly, marginalization and isolation. And then provide supportive care. So for today's lecture, I really want to do a little bit of a deep dive into what I've learned about belonging and why I think it's so important as part of this syndrome of distress we're experiencing in medicine. And I'll start by asking a question that's often a really good way to frame what you want to understand, which is, what is the opposite of marginalization and isolation? And it's pretty clear, I think, that it's belonging. So when you think about, well, how am I going to talk about belonging? What I decided is I would look for the 5 things that I think disrupt belonging the most, and then the 5 tools we can use to overcome it. So the 5 things that disrupt belonging are, first of all, the effects of social location, the binary of us and them, thinking we belong to an institution instead of a group within the institution, individualism, and power, especially if it's malevolent. So we'll start with social location, and it should be pretty clear that if the opposite of belonging is marginalization, which means being on the margin, the next thing you have to define is the center. Because for there to be a margin, there has to be a center. Each of us in this room, online, has a social location. It's a composite of our social identities, gender, race, age, all of those things that are in the middle there, and the things that are on the rim. It keeps going out. It can be very nuanced. And there is a dominant social location that's defined in every society. It is constructed. It's not innate. And in the United States right now, in particular in North America, the dominant social location is white, male, cisgendered, heterosexual, less than 60 years old, able-bodied, and not an immigrant. Now, what's important, also, in our world, in the world of academic medicine, we have a whole nother layer of social location, which is defined by where we stand at work. So how productive you are, who your mentors and sponsors are, what your title is in your department or division. There's these vague things of prestige and power, who you're related to, who you know, and all of these also contribute to our social locations. Now, the important part of social location to understand is that it defines what you can see. David Foster Wallace probably described this best in the introduction to his amazing commencement address, This is Water. There's these three young fish swimming along. They happen to meet an older fish coming the other way. Older fish nods at him and says, "Morning, boys, how's the water?" And the fish pass each other. And three young fish swim on for a little while, and finally one of them looks over to the other two and says, "What the hell is water?" So the water of American society right now is white, male, heterosexual, cisgendered, young, and able-bodied. It defines what you can see. Let me give you a concrete example. True story. Well-respected surgical leader, not in this organization, I will say, but someone you all know. Friend and someone I really consider an ally to women in surgery. Okay? And we would have banters back and forth about women in surgery. And he stopped me one day in the hall and was super excited because he said, "Mary, I heard that when women are introduced for grand rounds, they don't get their title used as often as when men are introduced." I didn't believe that, but I started paying attention, and it's true. Did you know that male physicians are introduced with their titles more often than women? To which I thought, only since day one of medical school. But what I said was, yeah, isn't that interesting? And that's fantastic. What are we going to do about it? No, I didn't go that far. It's true, actually. There's data that show that when women introduce grand round speakers, 95% of the time, regardless of gender, they use titles. When men introduce grand round speakers, for women, they use their title 50% of the time, and for men, 72% of the time. Now, you've already realized, I'm sure, that unless you are really a rare exception, you have one and probably several social locations that are not dominant, which means we have to talk about intersectionality, which is the concept that all marginalization is connected. It's not just additive. If you're a Black woman, you are profoundly more affected by this than a Black man or a white woman. Let me float another thought by you that applies to all of us. This is the time of my career. This is the time of lots of people in this room's career. The rust color is the growth in managers, and this stops at 2015. I haven't been able to find data since then, although I suspect, and you do too, it has continued to increase dramatically because we've seen it in our lives. The little green at the bottom is the growth in physicians. There has been a profound change in the center of control in our professional lives. And as a result, we have all been marginalized. Those of us who previously were physicians and other healthcare leaders had the center of control in terms of policy and finances. That's shifted. We've literally been pushed to the margins in a lot of decision-making in hospitals and medical schools. The second of the 5 things that can disrupt belonging is this, that for there to be an us, there has to be a them. This is hardwired. Okay, people that say I don't see color, people that say that I don't, I just accept, that is absolute baloney, because we are all completely hardwired that anyone who's different from us, we automatically recognize as different because our primitive brains say, until you prove it's not a danger, it is. That is to protect us. This backs a reality of human psychology and is one of the hardest things to overcome in creating a culture of belonging. Each of us has this hardwired ability to see someone and instantly assess if they're part of our tribe. And like our immune system, it's a warning system to protect us. But I also think that like the immune system, if we allow it to blow up without the guardrails of culture, it becomes destructive. The third thing that disrupts belonging is confusing places and people. And if you don't know Simone's maxims from this very famous paper, he describes what life is like in an academic medical center. But his most famous maxim is this: the institution does not love you back. Confusing the place we work with, the people we work with, is a big cause of disrupting belonging. As he goes on to say, the one must keep in mind that institutional relationships are really with persons who can and sometimes do love you back. For any one of us, good coworkers and solid leaders make what we value in the institution. Recognizing them, what they do for us, and the values they represent are far more important than loyalty to an impersonal institution. The fourth thing that disrupts belonging is individualism. Western culture in general, and American culture specifically, is situated in a context, as Peter Block describes it, of scarcity, competition, and individualism. This leads us to believe that our work is a zero-sum game, that we only get what we keep someone else from getting. That alone is enough to disrupt belonging. But the most detrimental part of this whole concept of individualism, that again is water that we're in our society, is it sends an absolute explicit or implicit message that you're on your own. What you succeed in, how you fail, is your responsibility. That is completely isolating and extremely detrimental to belonging. The fifth is power. Power is a social technology. People with power can make huge changes for good. The roads that the Roman Empire built are still being used in Europe. But it's also their lust for power and the astounding oppression that was the cost of doing the work that the Roman Empire did that contributed to the fall of Rome. Power is part of our social structure. It is a social technology which can be used for great things, which means the challenge today is no different than then, to use power for innovation and good without oppression. This is a very profound painting. How many of you have seen this painting before or know what it is? One in the back. I used to assume a lot of people did. So the man on the far right is J. Marion Sims, who has been quoted as the father of modern gynecology, but the story is horrific and part of our history we need to know in medicine. The woman on the table is one of 12 slave women who he operated on 20, 30 times each to develop a technique to close fistulas after childbirth without anesthesia. They were brought by their owners because they couldn't work and because they couldn't breed. And that is the word that was used. So power for innovation. He invented the speculum. He invented multiple operations. Power can be used for good, but we have to make sure it's not done with the cost of oppression. So there's the 5 things I think we all need to know about that can disrupt belonging. Social location, the binary of us and them, thinking we belong to an institution when we actually belong with people, individualism, and power, especially if it's malevolent. So what are the tools that we can use to disrupt? 5 of these as well that I'll tell you about so you can put them in your toolkit. Asset framing, contextual creativity, storytelling, rituals, and measuring what matters. Asset framing is the opposite of what I described earlier, because we're hardwired to look for danger. Other people that aren't like us. It's instant and automatic. We don't have control over it. It was developed by Travian Shorters, this concept, who describes himself as a social entrepreneur. And it has 3 parts. And all 3 are important. You can't exclude any of them for this to work. First of all, asset framing is not what you say about people. It's what you think about them. So we all learn words that we're supposed to say. This goes one level deeper. And he says, is your first thought about the person in front of you one that affirms their spirit? That's how you know if you're on the right track. And if it's not, what are you going to replace it with? Then you start any conversation, any conference, any discussion with the aspirations and contributions of the people who were there. And then at the end, include what's obstructing those aspirations and contributions. Contextual creativity is the second tool. It's got 4 steps that are easy to remember. Name it, frame it, enact, and revise. And it's probably best to tell you, again, a story that illustrates this rather than try to describe it in detail. I spent a few years in New Orleans and was part of a committee at our hospital to develop a common space for everyone that worked in the hospital. Coffee, nice place to sit, and the hospital commissioned an artist to put up a huge mural, and they asked for an oak tree because it was such a great representation of New Orleans, the land, all of the people that had been there, the centuries. And the artist came in with this absolutely beautiful drawing for us to approve. And it was spectacular. And we were all just, let's do it. And then a good friend of mine, a Black physician, spoke up and said, that's not what I see when I see that oak tree. That a beloved colleague could see this as a sign of lynching when it had not even occurred to me was a profound lesson for me. So we name it. That image is going to make some people think about lynching. The next is frame it. Framing what we name is the basis for changing the power of the past. Naming it alone is not enough. You have to frame it in a way that leads to actionable and benevolent terms. So we frame it and we say, we can't have an image in our community that reflects lynching to anyone, which gives you exactly what needs to change. You need a different image. 24 clicks. For those that are online, somebody's thing went off and just said CBC. So, then the 4th step is revise, and this is like all of the quality things that we're all used to. You look at it, you see how you're doing, and you revise it if you need to make it work. Let's look at this with the example I gave you earlier, too. Name it. We're failing to introduce women with their titles. You frame it. Respect is important to feel like you belong, and titles reflect respect. You enact. We set an expectation that titles will be used for all speakers, and then when people mess up, because they will, we correct them with kindness. And then we look at it every once in a while. Are we still doing okay? Do we need to change it? Is there anything else we need to add? The third important way to create belonging is storytelling. Owen Eastwood calls this the story of us. And as he explains, storytelling fuels the super strength of Homo sapiens, our ability to form tightly bound groups. Stories of us explain our shared identity and describe for us the type of person you need to be part of our tribe. We need to tell our origin stories over and over again. We were doing that earlier today. I think in medicine, this is really just part of our culture. as it is, I think, for all groups, but especially in medicine. And we need to amplify stories that reinforce who you are as a team. So this is a post on social media that I made that said, when a child who's been in the hospital for a long time finally starts smiling and lets you know he likes hot sauce, you go to the store. This is like a little story, right? But it does amplify what kind of team we want to be. We need to include everyone and acknowledge history that excludes some. Now, we're all doing better with this, but we need to remember to look at things that are on our walls and say, who's not here? Because for a Black woman to walk by this wall is immediately an assumption of not belonging. And it's a deep psychological assumption. So it is important to pay attention to how we display our history. Rituals. Graduations are profound rituals in healthcare. We not only graduate, we take an oath. We realize it's a ritual that makes it clear we aren't just graduating, we're joining an unbroken chain of healers. In my experience, most of the time when a physician joins a group, they're introduced at grand rounds, there may be a dinner, but that's usually it. What a missed opportunity. Why not create a ritual to share the aspirations and contributions of everyone who's in the group and celebrate the gifts that are being brought to the group with the new person? First cases, this is one of my favorite examples. I hope they're still doing it, but for a very long time in the neurosurgery department at Baylor, there was a ritual that anytime a resident did a first case, they had to go to the cafeteria and buy ice cream for the whole team. So we're not talking about fancy rituals and oaths here. We're talking about creating those things that connect a team in a very special way, and sometimes that's ice cream for your first case. And then how many of us have been to funerals and listened to the eulogy and the stories and wished that the person there could have heard them? I think we need to think about that seriously and create some rituals and just a habit of sharing those thoughts before it's too late. And then the fifth thing we need to do is measure what matters. It's a fact that our current healthcare system concentrates almost exclusively on financial measures of success. Even our idea of quality is framed as part of value, which has cost as a denominator. All of us want to be paid fairly, but if we were just interested in money, none of us would have chosen medicine as a career. What matters to us is not exclusively financial. It's become common practice in virtually every hospital system to report individual RVUs and benchmarks to every physician and nurse practitioners and APPs as well. In many cases, these are also shared in group, division, or even departmental meetings. We are highly motivated people who love our work. This kind of productivity reporting is a business practice, and there's a big problem with it. It reinforces the concept of individualism and psychologically puts us all in competition with each other. The same is true for battling for OR time, clinic slots, office space, conflicts which are equally destructive to a sense of belonging. Most of these conflicts are the result of financial decisions made by administrators, but I want to be completely clear here. There's no administrator who gets up in the morning, looks in the mirror, and says, I'm going to go torture the doctors today. We are different tribes. We do think about things differently. We work as one whole to make the systems work that heal people. It's important we make sure that we don't create another binary of us and them as we work to create belonging together. And then there's some other things. How do we put into the value part? What metric do we have for the incredibly important work of educating future physicians and training future surgeons and cardiologists and all healthcare people? How do we measure important research, which will change the way we treat patients, especially when it's not supported by grant money? And what if what matters to an individual is a profound desire to give back to the community? Higgins, in this 2020 article, reminds us that with the shift in physician workforce demographics comes new perspective, career aspirations, and concepts of how to have a meaningful impact. Meaning and purpose may be spurred through efforts to give back to the community or provide outreach. One of the shining examples of this is Dr. Ayla Stanford, who's a pediatric surgery colleague of mine, who during the pandemic recognized a completely unmet need and mobilized a group of physicians to provide COVID testing and immunizations in the Black community in Philadelphia. This has gone on with numerous awards and accolades, as she should have gotten, to become a center for inequity in healthcare. This is very important work. There's no RVUs associated with it. There's no income, but it really matters. So there's the 5 tools for creating belonging. So I sort of reviewed where we are now, how we got here. I talked to you about the new paradigm to understand burnout, and I talked to you about belonging, things that destroy it, things that we can use to build it. But now I'm going to tell you why I think we need a grassroots revolution and how you can become part of the change. Wellbeing 3.0. Vivek Murthy published a white paper in 2022 entitled Confronting Healthcare Worker Burnout and Wellbeing. In it, he said, the time for incremental change has passed. We need bold, fundamental change that gets at the roots of the burnout crisis. We need to take care of our health workers and the rising generation of trainees. Wellbeing 2.0 is about data and moral appeals to administrators to change the culture and to provide the people, space, and money necessary to do our work well and keep us well. But Wellbeing 3.0 has to be this bold, fundamental change that gets at the roots of the burnout crisis. And what is that root? I think the real root cause underlying all of the other issues is the moral distress that we're feeling. And the definition of moral distress is knowing the right thing to do and being in a system that doesn't let you do it. And I think that's because we have resources that are insufficient or unfairly distributed. We have corporate models that we perceive as putting profit before people, both our patients and ourselves. And we have this marginalization of physicians and other healers that's happened that has led to this lack of belonging. So that's easy, right? How are we going to fix that? This huge thing that we're going to overcome. Well, first of all, I think we all have to commit to pushing back against anything that disrupts belonging. We have to become fierce creators and guardians of belonging with these tools or whatever other tools you find. But I also think that how we can become part of this change is actually 3 simple things that I really truly believe if everyone adopted, we would see a huge change. And they're these 3 things. These are the tools to put in the toolkit for this grassroots revolution. To lead with compassion, to speak the truth, and to decide who you work for. Compassion's first because it's actually really a superpower. It benefits your patients, your colleagues, your family, and friends. It serves individually for you as an antidote to stress and distress, and it really works, so it benefits you as well. It allows us to stand consistently strong in the middle of any storm, and it provides clarity and ease when making complex decisions. It's really a superpower. But compassion I'm talking about is not just a feeling. And I put this book up. This is Inner Practice of Medicine by Wendy Lau. She's an ER physician and a Buddhist practitioner who during COVID realized she was having to show up every day completely depleted. And she took some of the practices she learned in Buddhism and applied them, practices to build compassion, and realized it gave her a way to be there, to show up that actually started benefiting her and changing things in the system. I view this as almost a textbook for physicians on how to learn the practice of compassion, because it's real important to understand exactly what we're talking about with this word, right? And the difference between sympathy and empathy. So sympathy is feeling sorry for someone, and that's a very mental thing. Empathy is mirror neurons. It's feeling sorry with someone. It's actually experiencing some of their grief, some of their pain. But compassion is the next step in that empathy, which is being moved to act to relieve some of that pain. And that's not a choice. We don't decide to be compassionate. We can decide to act for someone's benefit, but the feeling of compassion is something that wells up in us so that we're moved to relieve the suffering in front of us. And so our responsibility is to learn the practices and ways to let that happen more often and more effectively. And that's the practice of compassion. That's why it's important to learn it and to lead with it. We have to speak the truth. There was a time in the OR lounge a year or two ago when I was thinking about this, that the residents came in with yet another huge onerous module, something they had to do that was total meconium, as we say in pediatric surgery. And I just looked at them and said, that's not normal to ask you to do that. And it kind of hit me because they all went, no, it's not. That we need to, when things really are not normative, which is probably the better word for this, be able to recognize that and say it out loud. So you may be told by your employers that you have to cut your clinic times from 15 minutes to 12 minutes, and you may not have a choice because they pay you. But you can absolutely, to yourself and to your colleague next to you, say, that's not normal. That's not the way a clinic is supposed to be set up. That gives you agency to recognize and understand where those boundaries are, rather than being sort of a victim of the things that are being done to you. So say it to your colleague, say it silently in your head. Every once in a while, it may be appropriate to go say it to power. It may be important to go say it to somebody. But most of the time it won't be. You've got to pick what those battles are. But don't hesitate to do it for yourself so you don't lose track of what's normal in medicine. Because it's not normal to not see a dentist in 3 years. It's not normal to have to rush a visit with a tearful and frightened patient because your clinic is so overbooked. It's not normal to stay up all night and then work a full day the next day. It's not normal to have to go immediately to your next task after losing a child in the emergency room. And it's not normal after 10 plus years of training to spend hours at home typing in Epic. And this is not normal. The third thing that you have to adopt to be part of this is to decide who you work for. Because who employs you is not necessarily who you work for. And I would argue that we work for our patients, our trainees, and each other. So that's the bold fundamental change. Compassion, truth, and courage. To lead with compassion, to speak the truth, and to decide who you work for. And I think you would look at that and think, you know, if there were enough people that really did that every day, I think you'd agree with me, things would really change. And so the next question is, how many of us have to do this for it to really change? And like most of you, I thought it was going to have to be 50, 60% of us. But there's actually good data from sociologists. And it comes mostly from marketing. The law of diffusion of innovation. We've heard this. There's people, when changes start, there's early adopters. Then it goes into the early majority, late majority, and late, but it goes. There's a point that's called the tipping point. And that tipping point is at 17%. I believe that 17% of us lead with compassion, speak the truth, and decide who we work for, that things will really change. So that's my appeal to you. It's resolved to be part of that 17%. Thank you so much for time and for allowing me to speak to you today.
Well, thank you so much, Dr. Brandt, for being here with us today and for coming back to Methodist to teach us again. As a teacher to the teachers and the educator for the educator and the healer for the healers, I thank you for carrying this message. It's so critical that we understand the roots of the problem to be able to attack the problem, as we always do in medicine, but we don't seem to do for ourselves and for our colleagues. And I noticed for an hour you talked about wellness, you never said the word duty hours. And I think, you know, we always measure the measurable, and we emphasize what we can analyze. And so I think this really brings up an important point to us, that we need to look beneath what we can measure and look at the consequences of our actions at every level. So thank you for being here, and I really appreciate it.
Thank you. And a word about duty hours, because I think it's actually a really good example, right? There was a problem with people being exhausted, no question, right? So we pass a rule that what happens is the unintended consequences of that, first of all, has been a shift work, which totally takes away from that connection we have with patients and our desire to be present for them and to heal them, changes psychologically very deeply. It also, you know, ends up with a lot of other unintended consequences in terms of fatigue and disconnection and belonging. You know, you're on your own as the float resident. That's not a community that's supporting you. So I think it's a really good example of trying to do the right thing and not thinking through what the real problem is. Because the real problem is not duty hours. The real problem is all of the clerical and unnecessary work that residents have to do rather than learn their task. And the root cause of that is how residents are paid, and that technically they're employees of the hospital. And so you have to keep going back and not put the paint on the wall if the problem's the foundation. Not that I feel strongly about that one.
Thank you so much for coming and talking something beyond science, although this is science of a different kind, if you will. And I think it's very important for us to think about what we do, how we do it, and how effective we are, and our well-being. And I think these are very important. A couple of questions and maybe thoughts. One is, from the times we trained, and I look around here, things have changed. Mm-hmm. Not necessarily only the stress of the work, but the work is a bit more stressful, because if you think about the volume of patients that you're seeing, also there are stressors from the outside that you have not mentioned. I don't know if it is. And the stressors from the outside is more recognition of work-life balance, more recognition of individuals, be it men or women, of having to spend more quality time with their families, and social media, which is completely new and puts stress on any working individual, be it physicians, yes or no. And the question is, how can we alter our perception of this, and how can we manage that to try to improve it? And the last question for you is, you talk about compassion as part of, can this really be taught? You can talk about it, but can this be taught and change behavior?
So the last question is, I think, the best. You cannot teach compassion, and again, compassion is not a choice, but everyone in this room, unless you are in the 4% of people that have serious psychopathy, which is 4% of the population, so 96% of people have the mirror neurons, right? When you see a child who's crying in the grocery store because they can't find their parents, we respond to that, right? And the compassion is the next step that kind of wells up with you, which I have to help this kid find their parents. That's a trivial example, but what we can do is create situations where we notice that situation more and we understand how to respond better. Empathy drains us. If we have nothing but empathy for people without building the compassionate part into it, we're drained by that. But compassion can never run out. It's one of the fascinating things when it's been studying. So taking these practices and learning the practice of compassion is protective for us and generative for the whole profession. Now, your other question, so if you want, can you sum it up again so I don't lose that important thought? How do we deal with social media? And
The other factors that are not necessarily within the confines of daily duties that influence and put stress on individuals. You know,
Totally.
the work-life balance, which a sentence that we never used before, right? You just did the work and figured out a balance one way or another behind the scene. But now it is upfront. And in truth, I mean, the electronics, social media, so many other things, people try to figure out, you know, how much time do you spend there? Because the more time you spend interacting with people outside you, it just drains you. And what I tell people is that I don't spend more than 15 minutes per day on social media. So you have to manage time to be able to decrease the burnout that we're really talking about.
Good points. There are so a couple of thoughts. One is, there's no question, you know, since we trained, higher acuity, higher numbers. You know, nobody's in the hospital for a week with a hernia or 2 weeks with a simple myocardial infarction. You know, so the acuity of people on the floor has gone way up. The numbers have gone way up because we're not meeting the demand with physicians and providers, and I use that term in the billing term. So that, you know, I said I didn't use the word provider, so I'll tell you why, because that business term refers only to people that bill. And the other reason I don't use it is that in Nazi Germany, that was the term that was given to Jewish physicians when their physician's license was revoked, and they were called providers. So I think we need to get rid of the term provider, because that's not what we're doing. We're not providing a business. We're taking care of people. So that was a sidebar, but things have absolutely changed. It's gotten harder. And as a result, if we don't recognize that and we don't deal with it, that's another cause of injury. It's adding work without dealing or discussing with it at all. In this climate where what we're measuring is actually outputs and productivity. And that's, I think, what's the major destructive force that's happening right now. And I agree with you about social media. Someone told me the other day, our real task in these days is to curate our attention. That's a really nice verb to use that, like a curator in a museum, to make specific decisions about who's going to own your attention. Because social media, regular media, everyone, people want your attention. Some people use techniques to grab it and not let you let go. And so you have to curate your attention. I agree with that.
Any questions from the internet? So thank you again for opening our eyes and opening our minds to this idea. And I know you have so many friends and colleagues here and people that you remember from Baylor College of Medicine and Methodist Hospital. Any particular memories you'd like to express?
I'm still getting over my PTSD, so I had wonderful training here and made great friends. And there's quite some stories, but most of them I can't tell. One more question.
Hi, Dr. Brandt. I was with you in the DeBakey Summer Surgery Program in 2014.
Wow.
And so you mentored me then. You probably don't remember me because you mentored so many people, but I'm a third-year cardiology fellow now. You were also my dean in medical school at Baylor.
I do remember, because I was going, that's not just a summer thing. But I don't remember you well, which is a good sign if I was your dean.
But I just wanted to thank you for all the mentoring you've done. And I remember one of the first things you told me in the summer surgery program was in medical school, there's a bell curve. you're coming from the top 1% when you're in your high school and college. And then in medical school, there will be a new bell curve of all the people in the top 1%. So it's okay to do a little worse than average. And I think that really put things in perspective. And then you told us things like you'll double your medical vocabulary. It's like drinking from a fire hydrant. So I think you normalized things feeling overwhelming and when to seek help. So it goes hand in hand with the lecture you have. So just thank you for all your mentoring.
Oh, thank you for saying that.